There are three basic valvular diseases. The first is diseases of the actual valves themselves. That's self-evident. But the other two diseases include infectious endocarditis, often referred to as IE, and the third is going to be rheumatic fever, which we don't see in the United States, but is a common disease in the undeveloped world. So valvular diseases are associated with murmurs. So let's just start off with the basic anatomy there. You can see we've got the image here, which are the basic areas to listen for the heart sounds. But rather than just memorize your heart sounds, it makes much better sense just to learn the anatomy, and then they make perfect sense. So let's just put in our diaphragm here, and then we can see that our heart is basically going to be there. So if we're going to say, where do we find the valves in this? We're going to find our aortic valve there. We would find our tricuspid valve there. We would see our pulmonary artery valve there, and we would see our mitral valve there. And so then when we say, well, where are we going to listen for murmurs from those valves? Well, it becomes pretty self-evident. We can see that we're going to see or hear the murmurs where the ejection flows strike. So we're going to see the mitral valve is going to be here at the apex of the heart. We can see that the aorta is going to be here, which is going to be the right second intercostal space. We can see that the tricuspid valve will be where the jet strikes just below the sternum, and then the last of our listening spots will be here where we see the ejection flow of the pulmonary valve in the left second intercostal space. So anytime you get asked to do a murmur, you're going to have to listen in the right area for the aortic versus the mitral valve. The second thing we should think about is, well, how do we want to actually imagine the valves in our mind's eye? So if that's our heart, it's the long axis view that really gives us the best view. And so the long axis view is going to look like this. Always start with your annulus fibrosus. Annulus fibrosus is the fibrous skeleton that everybody hangs off and the valves are built from. And remember, it's electrically inert, so it separates the atria from the ventricle. And then we're going to draw in our thick-walled left ventricle, our thin-walled, compliant, low-pressure right ventricle, our left atrium with the pulmonary veins, and then our right atrium with the superior vena cava and our inferior vena cava. So that's the mechanical heart. And then as we've been practicing through this whole thing, we're talking about how to do the conducting system. So we're always going to have our SA node, our AV node, and there it connects to the bundle of His, which is how we get through the inert annulus fibrosus. Bundle of His goes into the right and left bundle branches, and then the smaller branches coming off that are going to be our Purkinje fibers. So anytime we do a murmur, we want to coordinate it with the electrical system that drives the contraction of the ventricles and gives us our heart sounds. So if we're going to simplify this, because basically we only really care about the left side of the heart, then the way we want to think of all of our murmurs is we want to draw left ventricle, we want to put in an aorta because that will give us our aortic valve, and then we want to put in our mitral valve, and then we can draw our left atrium above that. So that's going to give our left atrium, our left ventricle, our mitral valve, and aortic valve, and pretty much everything we need to do with the valves we can do off that diagram. So let's talk about the common four valvular defects we need to know. Let's start with the classic, which would be our mitral stenosis. So mitral stenosis, we only see it in rheumatic fever, so in America our patients are all going to be immigrants. And if we talk about where we're going to see that defect, draw in our basic valvular marker. There's our mitral valve, and there's our left atrium. And in mitral stenosis, we are going to see thickening and scarring of the ring and the valves. And remember that the mitral valve has a tether system with our chordae tendineae going down to our papillary muscles. And these also are going to be thickened and scarred. So if we were to look across that image and look down on the valve, what we would see is we would see this slit-like structure with these thick, rolled, scarred edges that has always been called fish mouth. And obviously we're not talking about a shark here, we're talking about something akin to a carp. And when we talk about what the pressures are going to be, because this is going to be a very narrow hole here, the whole problem with the disease is going to be marked increase in the left atrium, but normal pressure in the left ventricle. So if we want to say, well, what would we hear on auscultation, we always want to correlate our murmur with the EKG. So here's our P wave, PR interval, QRS complex of ventricular depolarization to contraction, and then our T wave of repolarization. So if we then do our heart sounds and compare it to that, contraction is going to give us the S1 of the mitral valve, and just after repolarization, we're going to get the S2 of the closing of the aortic valve. So if we have mitral stenosis, we're going to see the opening snap of that thick, fibrous abnormal valve, and then we're going to see the murmur of the left atrium pushing the blood through the, quotes, fish mouth. So that's going to be a diastolic murmur. When we talk about mitral regurgitation, let's take a look at our heart here. There's my aorta, there's my mitral valve, there's my left atrium. And remember that the construction of the mitral valve is that it has the chordae tendineae going down to the papilla, and there's going to be two. There's going to be the anterolateral and the posteromedial papillary muscles. And in mitral regurgitation, then, we can see that we're going to have multiple areas that can be abnormal. The first is that we can get dilation of the mitral valve ring. That's classically a degenerative problem. Next, we can get distortions of the valves themselves, things like rheumatic fever. Just degenerative changes such as myxoid degeneration is another common problem that we have. The third area that we can see problems is in the chordae tendineae, and that's often the way we describe mitral valve prolapse with elongation, giving the so-called parachute deformity. We'll talk about that in a sec. And then the last thing we can get here is we can get rupture of the papillary muscle, which would be postmyocardial infarction. And you've noticed I've picked the posteromedial, which is 90% of them, because it only has the single blood supply of the right coronary artery. So what do we mean when we're talking about that parachute defect? Well, what we're talking about is if we looked at the closing of the valve, so let's draw our valve in here, then normally our valve would be coming down here and here attached to our papillary muscle. But if that chordae tendineae was too long, then late in the contraction, we would see the ballooning of the abnormal leaflet, and that would then open up the defect that would allow for the later regurgitation. So what are we going to hear? This is going to be in the mitral valve area. Let's do our EKG. So there's our P wave, PR interval, QRS of depolarization, T repolarization. So that's going to give us our mitral valve. That's going to give us our aortic valve. And we're going to see two patterns of defect. In our standard mitral regurgitation, what we would see is we would see a holosystolic murmur. But if we were talking about mitral valve prolapse, then what we would see is because it's this parachute phenomenon of the late ballooning, we would see an opening click, and then we would see the tapering of the murmur into the systolic contraction. When we talk about the pressure gradients that we would see in mitral regurgitation, then what we would see is we're going to see an increase in left atrial pressure, and we're going to see an increase in left ventricular pressure, both sides having an increased end diastolic volume and therefore end diastolic pressure. Aortic stenosis, let's form our mental image of how we want to see aortic stenosis. There's our aortic mitral valve, left atrium. In aortic stenosis, we're going to be seeing the narrowing of the aortic hole, so that if we were going to cut across that and look at it end on, there are going to be 3 valves in the normal aortic with 1 non-coronary, right and left. And anytime we see closing of those fissures, then we're going to see a narrowing of the outlet. And remember, Poiseuille's law says that flow is proportional to r to the 4th, and if the typical aorta is about 3 centimeters at that site, well then when we see 70% occlusion, that's going to be about 1 centimeter, which is a hemodynamically compromised aortic opening that will require corrective surgery. So that's going to give us a very high pressure here and a very low pressure in the aorta. And just to think through pathologically, anytime you have an increased afterload, then we're going to see concentric hypertrophy. If we take a look at the murmur, we're going to see our EKG, which is going to give us our P wave, QRS, T wave, and that's in our terms of our sounds. That's going to give us an S1 and an S2, and this is obviously going to be a systolic murmur with our classic crescendo, decrescendo murmur. Remember, this is going to have abnormal pulses, which are going to be delayed and diminished. And then the last of the important murmurs we have to be able to talk about is we have to be able to talk about aortic regurgitation. When we talk about aortic regurgitation, let's draw our image for ourselves here. So here's our left atrium, here's our aorta, here's our mitral valve, and there's our left atrium. So we're talking here about the aortic valve. And the defect is either going to be abnormalities of the valve itself, or the more common situation, which is going to be dilation of the aortic root. And that's going to leave us with high pressures here that collapse after contraction, and obviously very high pressures into the aorta. So when we talk about the murmur that we're going to hear, here's going to be our EKG, PQRST, PQRST. So this is going to give us an S1 and an S2. Here's our mitral valve S1 and here's our S2. Then this is going to be a diastolic murmur in which we're going to see the blood flow collapse after contraction of the left ventricle. Remember, we're also going to see very abnormal pulses here. These are going to be bounding pulses. The patients can actually feel them pounding into their head, and when you palpate them yourself, you're going to feel the so-called water hammer of a rapid onset and then collapsing pulse peripherally. So notice the aortic valves not only give you a murmur, they also give you a pulse finding. When we talk about the causes of what's going to be these two different things, remember we're going to be talking, one is going to be abnormalities of the valve leaflets, but the second is going to be all the causes of aortic root dilation. So, take a look at how we compact all of the information we need about the various causes and presentations of these valve defects into this one very powerful table. And it really condenses all the information you need and just saves you pages and pages of reading. So when we talk about mitral stenosis, Really, the only cause that we're going to have to ever worry about in life is rheumatic fever. And remember, we don't get rheumatic fever in North America, so this has to be an immigrant. When we talk about the pathology, we get scarring of the valve, of the ring, and of the chordae tendineae that give us the classic fish mouth appearance. The presentation is going to be twofold. The first is, remember, you're going to get a really big left atrium. And that can create a mass effect, which can give us a mild degree of dysphagia by pushing on the esophagus, and it can even push on the trachea and give some mild degree of dyspnea. But at the end of the day, there's decreased filling of the left ventricle, and so they're going to present with forward failure from decreased cardiac output. When we talk about the murmur, it's going to be a diastolic murmur, which is going to give us our classic opening snap with the diminishing murmur into the end of the contraction of the atrium. Mitral regurgitation, you notice we have a number of entities. It can have abnormalities of the valve ring, and that can be things like degeneration, rheumatic fever. Very different than mitral valve prolapse, which apparently is an elongation of the chordae tendineae and papillary muscles. So we think of that as a different part of the ring, and then papillary muscle is just simple rupture, just like the name describes. And when we come to the etiology of this, the key things that we want to identify in mitral regurgitation is that we can see in here the usual rheumatic fever is present, but we can also see this is where we get the connective tissue diseases of Marfan syndrome, of the elastic fiber, and Ehlers-Danlos of the collagen. Papillary muscles are post-myocardial infarction, most commonly occurring in the first week before there's any fibrous strength. Presentation of mitral regurgitation is fundamentally going to be shortness of breath from decreased cardiac output. That's very different than mitral valve prolapse, which is found in 2% of American females, and so it's mostly going to be asymptomatic. And then papillary muscle rupture is going to be a complication in the first or second week of myocardial infarction, and it's going to present as an acute heart failure. So that will be a shortness of breath. When we talk about the murmur of mitral regurgitation, we're going to think about it in two different patterns. We're going to think about the full mitral regurgitation, which is going to be our holosystolic murmur. We're going to think that a little bit differently than when we think about our mitral valve prolapse, because we're going to think of that as the parachute phenomenon. When the cord snaps open is often going to give us a click, and then we're going to see the diminishing murmur as the atrium finishes contracting. Aortic stenosis is going to have a congenital versus an acquired or degenerative etiology. Congenital is going to be our bicuspid valve, whereas degenerative is going to be dystrophic calcification. And obviously this is a much older person, commonly in their 70s. When we talk about how they present, remember with aortic stenosis, we don't have large stroke volumes, so these patients can often present with shortness of breath. If the stroke volume is really small, then we don't get an adequate systolic pressure. And anytime systolic pressure drops less than 60 millimeters of mercury, we don't get perfusion of the coronary arteries, and so the patient can present with angina. And then for obscure reasons, probably related to inadequate stroke volume, these patients also get syncope. When we take a look at the murmur, it's going to be our classic crescendo, decrescendo murmur in the aortic space. And then our aortic regurgitation, remember we're going to talk about two different areas of pathology. We're going to talk about pathology of the valve leaflets, And that was going to be our standard list of rheumatic fever or iatrogenic after a procedure. And that's going to be really different than our commonest, which is dilation of the aortic root. Well, you can make that the same differential diagnosis as aortic aneurysms. So you don't have to learn two different lists on that. Remember, the commonest cause of aortic aneurysm in the elderly is going to be cystic medial degeneration from hypertension. It can be associated with a bicuspid aortic valve when you get root abnormalities with that. Obviously, we get it with the connective tissue diseases of Marfan's disease and Ehlers-Danlos. And so about the only new member of the list here, of course, wait a minute, don't forget syphilis. Never see it, but it's always on every medical student's list. But the one we don't really think of being common here is going to be connective tissue diseases. And that classic disease for this is ankylosing spondylitis. When we talk about the findings, patients are typically going to present with heart failure, so that will be a decreased cardiac output, shortness of breath problem. But remember as well, these people have abnormal pulses. These have the bounding pulses of the so-called water hammer. They can be so profound in the carotid arteries they actually get head bobbing. And when we take a look at what that murmur is going to look like, it's going to be our diastolic murmur in which the pressure drops over the aortic area. So that's a pretty powerful table, and you can appreciate we can organize all our information in one tight practice area. Let's move on to infectious endocarditis, which is often, when you talk about the subject, abbreviated to IE. This raises the big philosophical question of the different types of infections. And I think a really good way of thinking about infections is divide them into three different types of infections. One type of infection we want to think about is going to be pathogenic. When you say pathogenic E. coli versus just E. coli, well, what is a pathogen? Remember, a pathogen is an organism that can infect a normal person, which means they have a way of evading all of our innate and adaptive immunity. So that kind of pathogen is what we really mean when we're talking about a virulence factor. So they tend to be fairly distinctive organisms, so these infections tend to be single organisms. And that's really different than when we talk about our opportunistic infections. Because opportunistic infections usually have some basic abnormality that's going to be mechanical, which means that the organisms are usually from our normal flora. And they can often have multiple organisms. And then the last of our great infections is going to be our immunodeficiencies. And these are going to be innate defects of either the innate acute inflammatory system or the adaptive. So when we talk about infectious endocarditis, this really gives us a good example to talk about the two different patterns of infection. And when you take a look at this table, when you fill out this table, if you give me any two of these, I can tell you exactly all the rest of the problem. So let's take a look at this. If you're talking about an acute infection, and by acute we're talking about something that is occurring over days, they're almost always going to be very severe, which means they're going to have very high fever. They're often going to have shaking chills, and they go rapidly into congestive heart failure, so they get short of breath. The pre-existing valve is normal, which means I've got to have a virulent pathogenic organisms, and indeed, this is almost uniformly due to Staph aureus. And it rarely has extracardiac manifestations because the patient goes into heart failure and dies in a few days if there isn't treatment. And that should be compared with subacute, because this is really a disease of weeks. This now has very different severity because this is now the symptoms of systemic inflammatory response syndrome. So think of this as the cytokine syndrome. So we're going to see things like fever and night sweats. We're going to be seeing things like weight loss. And we're going to be seeing things like malaise. So that's a pretty different picture than severe. And these patients have abnormal underlying valves. So stop for a second and ask, what are the two types of abnormal valves you could have as a Native American? Because that means no rheumatic fever. The two that you could have would be aortic stenosis and mitral valve prolapse. And now the organism is going to be coming out of your normal flora. And we see extracardiac manifestations because there's time for these to develop, because these are disease of weeks. And so we're going to see two different types of extracardiac manifestations. We're going to see septic emboli, and this is going to include things like our Janeway lesions in the palms and the soles. This is going to include our Roth spots in the eye retina, and it's going to include our splinter hemorrhages in the fingernails. The other group of extracardiac manifestations are going to be our immune complex manifestations. And so this is going to include our Osler nodes in the pads of the fingers and toes and glomerulonephritis. So how do patients get this? What's the pathophysiology of our infectious endocarditis? Well, we should really differentiate acute from chronic. When we talk about acute, there has to be direct access to the vein. So we're going to see this as two manifestations. It can be an IV drug user, and that often distinctively involves the tricuspid valve. Or it can be iatrogenic, and the patient had a medical procedure in a hospital with an IV device and got the Staph aureus that way. When we're talking about the subacute, that's really quite a different matter, because with the subacutes, we usually have to have some sort of abnormality of the overlying epithelium. And that's allowing the normal flora to enter into the bloodstream. And there it seeds, attaches, and proliferates on the abnormal valve. And so this gives us very distinctive organisms. So for example, if a person has an endocarditis from Staph viridans, we know that's normal flora of the mouth. So they probably had a dental procedure. If we had a group D strep or an enterococcus, well, we know that that's from the colon. So the person probably had a medical procedure. If we saw Staph epidermidis, like the name suggests, this is arising off our skin, and so the patient could well have had a procedure with laceration, or they could have just had a good big abrasion to let the organism in. And then there's one curious organism, which is Strep bovis, and it is distinctively associated with colon cancer. And no one can tell you exactly what that unique ulcer of the colon allows that particular organism is, but it's a well-recognized situation. Well, this brings us to a couple of special situations. The first of the special situations is going to be our culture-negative infectious endocarditis. You've got a patient you know has infectious endocarditis. They've got a new murmur, you can see the vegetation, but all of the blood cultures are negative. And this is the unique situation of the fastidious organisms, meaning they don't grow on our normal culture media. And this is the family of organisms which are the acronym of HASIC. And these are obscure organisms. I wouldn't bother learning all the names. You're more than welcome to. What I would do is instead I'd say, give me the best example. And personally, I think the best example is Eikenella corrodens. And I like Eikenella corrodens because it has a couple of distinctive things. The first is you get it from cat bites. That's pretty fun. And the other is when you grow it on the normal media, It smells like bleach. So if I was going to do a particular organism of a culture-negative infectious endocarditis, that would be the organism I would learn, but feel free to learn the rest if you're that kind of student. The other special situation we want to talk about is we want to talk about NBTE, which is the acronym for non-bacterial thrombotic endocarditis. In other words, they aren't an infection. And this is a situation where we go vegetations on the valve because the patient is hypercoagulable. Now, common situation you're going to see this is going to see when you see advanced malignancy. It's really common to see it, and if you do echoes on your heart patients in cancer wards, you'll often find them. But the distinctive situation that is worth discussing is when we talk about antiphospholipid antibodies. These are very common acquired hypercoagulation factors that are seen in 30% of your systemic lupus erythematosus patients. And when they do get their cardiac vegetations, these are the so-called Liebman-Sachs vegetation. And the significance is that they can embolize, and of course that would be disastrous, especially as the greatest embolic risk is for stroke. So non-bacterial thrombotic endocarditis are non-infectious. They just consist of fibrin, and they build up in hypercoagulable patients, and they're a distinctive entity in your lupus patients. So, who walks in the door? What's the presentation going to be of our infectious endocarditis? Well, it's obviously going to be someone that has a bacterial infection, so they have fever, and when you listen with your stethoscope, you're going to hear a murmur. So what do you need to establish the diagnosis? Well, we have major criteria and minor criteria. The major criteria, no surprise, are going to be vegetations on the valve, and you're going to find those by using echo. It's going to be a new murmur. That's your stethoscope. And you're going to have positive blood cultures. And then there are the minor criteria. Minor criteria include much more nonspecific things like a risk factor. It's an IV drug user. It's a person with a known underlying abnormal valve. Person has a fever. There are evidence of septic emboli. Or there are the immune complex complications. And so absolute criteria require any two major or one major and three minor. The treatment for infectious endocarditis has two considerations. The first is the actual valvular infection, which is going to require 4 to 6 weeks of an IV antibiotic, depending on what you're going to be culturing and its sensitivities. But the second is, remember, anyone with an abnormal valve requires prophylactic treatment anytime they're going to undergo a procedure that's going to shower the blood with normal flora. So let's conclude our discussion of valvular disease today with rheumatic fever. Remember that there are no cases in America. However, it's actually quite common in the undeveloped world. So if you're going to have a patient present with the disease, it's not going to be an acute disease, it's going to be chronic unless you're out of the country. The pathology of this disease, it's considered to be an autoimmune disease that arises in about 3% of any given strep pharyngitis. Now you notice it's a pharyngitis. You can get glomerulonephritis from either pharyngitis or cellulitis, but you only get rheumatic fever when it's the sore throat. and then the immune phenomenon typically starts to present 2 to 3 weeks after the infection. The disease is thought to be due to a cross-reactivity between your myocardial proteins and the bacterial antigens. There really isn't a well-accepted bacterial antigen that correlates to a given specific protein, so you can put any answer that your particular article gives to you. When we talk about the acute infection, it's not an infection, we talk about the acute condition, we're going to have a specific pathology which consists of areas of fibrinoid necrosis. Now you'll see that many authors refer to this as a type of granulomatous inflammation, and that's fine. After all, no one in North America has ever seen one, have they? And these areas of fibrinonecrosis are so-called Aschoff bodies. And within these Aschoff bodies, there is a distinctive macrophage. Obviously, I've never seen one because there's no cases of rheumatic fever in America. And this is called the Anichkow cell. When we talk about the chronic disease, it is a disease of decades. So you're typically not going to see your symptoms for 20 to 30 years. That's how long it takes for the fibrosis and the contraction and narrowing and loss of valvular function. The diagnosis of rheumatic fever is based on the Jones criteria. And this was a consensus in the 1960s, and probably the first one in medical history, where all the institutions got together and said, this is a clinical diagnosis and this is what you need to make it. And this divides into major and minor criteria. The major criteria, which you should know, involve the heart, which can be an endocarditis, a myocarditis, and a pericarditis. It includes the arthritis, which involves multiple large joints. It involves the skin, which is going to be our erythema marginatum. It's going to involve the CNS, which is Sydenham chorea. And it's going to involve subcutaneous nodules. Then there are the minor criteria. The minor criteria include arthralgias, much less specific finding than an inflamed joint. It's going to involve fever. It's going to involve an increased PR interval, which is really just a sign that you have a myocarditis. It involves any of the acute phase reactant findings that we do, so that would include, for example, an elevated SED rate or an elevated C-reactive protein, and then anything that gives you evidence of a group A strep infection. So that could be your ASO titers, or it could be a positive culture. And so you can make the diagnosis if you have 2 major or 1 major, 2 minor. And that brings us to the end of our discussion of valvular heart disease.